This is not us. Oh, I see. Got it, yeah. Hello, everybody. Welcome to this session. I'll get started. My name's Dan Dilling. I work at Loyola. I'm going to be talking to you today about managing fungal infections in the immunosuppressed patient. It's a case-based discussion. I'm going to be going through some cases. I welcome questions. I welcome discussions. I welcome whatever may come, although I'm also maybe pleased and feel safer that they've created a demilitarized zone between the audience and the speakers in this room, so that seriously, and there's audience response in this, so you can go into your apps and on this session there's a button there to click for how to poll and answer questions, and I think each of us will be giving you some questions, and we'll see how the audience thinks. So you can go into the schedule and then the session, and there it is. I have no disclosures or conflicts of interest related to the presentation. I will be talking about the use of some off-label medications in the context of the cases I'll present. Start with a roadmap. I'll talk to you a little bit about why suspect a fungal disease. We're going to talk about some cases, as I said already. We're going to talk about an approach to the diagnosis of fungal disease. We'll talk about some of the different organisms that we might see in the context of our patient consultations and some strategies for treating them, all in 20 minutes. So background on fungal infections is that there is an increasing number of these patients. We're seeing them more. Why is that? Well, more and more organ transplants, and for that matter, stem cell transplants and bone marrow transplants. We're seeing HIV patients. That remains a chronic disease with fungal infections as part of its context. Chemotherapy and the biologics that are used in rheumatoid diseases, as well as many other medical scenarios that leave people immunosuppressed. The key to approaching the patient is really to have an index of suspicion. We're going to be seeing patients from these various populations. You have to have your antennas up. You're going to maybe see your patient in follow-up of a non-resolving infiltrate, whether it's in the acute setting or chronic setting, and you have to have the antenna up. You have to have the right index of suspicion. There may be features on the CT scan of adenopathy or nodules that should raise your suspicion as well. There are also many more options for the diagnosis than there used to be. So besides cultures of the alveolar lavage or the pleural fluid and aspirating for organisms through a fine needle aspiration, we can also now have some options with PCR testing or antigen testing, or these assays called galactomannan and beta-D-glucan that we'll talk about. There's a big list of fungal infections in the immunosuppressed to be worried about. You can see them all there. I'm not possibly going to be able to go through all these, and I'm going to pick a few of them and go through them in a case-by-case basis. Similarly, there are a number of medications that are in our armamentarium for treating these diseases. They come into different, they're in different categories, and the treatment options for different fungi will sometimes fall into different categories of drug therapy. I'll start with a case of a 72-year-old man who had a left single lung transplant for IPF about 10 months ago, 10 months before the presentation here. He was on triple immunosuppression therapy with tacrolimus, myclophenolate mofetil, and prednisone. He'd had a previous acute rejection, and he was treated with a steroid pulse. That was just about a month before the presentation. He comes to me with shortness of breath, fatigue, weight loss, and a decline in his spirometry. And he has an abnormal CT scan that you can see here. You'll notice these are two slices of the same CT scan, and you can see that his right lung is his lung with pulmonary fibrosis, although there's some extra ground glass than you would normally expect, I think, related to his current situation. But also on the left side, the allograft, there's some nodular disease, even a little bit of a cavity that you can see in one of them here, and then on a slice a bit farther down, a thick-walled cavity with some material inside, abutting the pleural space, pleural lining. So in this patient, what do you think is the diagnosis? And this is going to be open to polling. Something didn't happen right. So look at the 4 choices there. You're going to have 1, 2, 3, or 4. Blasto, Mycobacterium tuberculosis, Aspergillus fumigatus, or Pneumocystis. So now, with those 4, let's see what you think. Oh, it was a dead giveaway, I guess. So indeed, it is. And so he undergoes transbronchial biopsy and what we found was a filamentous septate fungal hyphoform with the acute branching hyphae that you'll see on the upper panel there, and it is Aspergillus. And he was started on voriconazole, the standard first-line therapy for this. But there's more to the story than that, because you got this big cavity there with a burden of disease, and he undergoes thoracoscopic surgery with a left chest washout and decortication, as well as the abscess drainage. And he remained afterwards, and remains today. This is now 4 months ago. He remains on voriconazole, and he has improvement in symptoms and his spirometry, and you can really see the difference in the left panel at diagnosis compared to now. So Aspergillus is present in immunosuppressed patients, also patients with structural lung disease. Has several manifestations. We know about the 4 basic manifestations of Aspergillus with ABPA, treated usually with steroids and maybe with itraconazole in some cases, and aspergilloma or fungus ball that can be treated usually not with antifungals, although all of us tend to do so some of the time. But bronchial embolization and consider surgical resection. We have chronic necrotizing pulmonary aspergillosis, like the case that we just saw here, where it's treated with voriconazole and considering surgical resection as we did. And finally, invasive aspergillosis. We'll see this many times in our bone marrow transplant recipients. It's a very serious, somewhat lethal disease that is treated with IV voriconazole or sometimes amphotericin. So the diagnosis of Aspergillus is sometimes made through traditional smear and culture, but also can be just histology. And then we have these 2 tests called galactomannan and beta-D-glucan. So galactomannan is a polysaccharide released from the germinating Aspergillus and in its hyphae. The assay that we use to measure it uses antibodies to the residues of the galactomannan. The performance characteristics of the test are variable, and it usually depends upon what the clinical context is or this patient population, as well as the specimen type. But as far as cases of invasive aspergillosis, in looking at some meta-analyses of these, it has very good, although not perfect, sensitivity and specificity. And so this can sometimes be a good test for looking for this, remembering that there's sometimes a need for further testing given those operating characteristics. Beta-D-glucan, on the other hand, is a cell wall component of most fungi. They call it panfungal, although there are a few that we'll learn about that do not have beta-D-glucan. And it uses a clotting cascade from a horseshoe crab in its assay. And its performance depends, again, on the patient population being tested and the specimen type. This is really best in the neutropenic patients who've received bone marrow transplants. And as for cases of invasive aspergillosis, like the patient we just saw, sensitivity and specificity, again, in meta-analyses are variable, but some of them suggesting very, very good operating characteristics. Of note, this is really good, and this is a learning point, I think, for all of us, is that for cases of pneumocystis, it has excellent sensitivity, nearing 100%. What that means is that it can be useful in ruling out the disease in a patient who you might otherwise not be able to get a good sample on. And it also, but we have to remember that the specificity is not there because this is a pan-fungal feature. So it would be, if it was a different fungal disease, it would also be positive. So because it's positive does not mean it's pneumocystis. So with that said, what do you think is the answer to this? Which of the following cannot be detected with the pan-fungal beta-D-glucan test? So your choices are pneumocystis, 1, Aspergillus, 2, histoplasma, 3, or cryptococcus, 4. Which one's not detected? You guys are good. Cryptococcus, indeed, is not detected. So of all the pan-detected beta-D-glucan, it is present in pneumocystis, as I said already. Aspergillus, as we saw in this, as we could have seen in this case if we tested it. Histoplasma, it is. The ones that are absent of beta-D-glucan in their cell wall are the cryptococcus, the zygomycetes like mucor, and also blastomycosis. So those ones it would not be positive in. Remember also that there are some false positives with the beta-D-glucan test, and specifically beta-lactam antibiotics have been seen to do that. We'll have another case, and this is a 45-year-old woman with HIV who's not on therapy. Her CD4 count is 50. She has fevers, fatigue, cough, and shortness of breath over the course of a month. And her chest x-ray is abnormal, as is her CT scan. I don't know if it displays well from the back, but on the chest x-ray there is kind of a diffuse interstitial pattern here, and you can see it more clearly on the CT scan. These are some sort of lower, there's a crinocut actually, and you can see there's ground glass opacities in the dependent regions, but all through there you can really see ground glass attenuation. So on ABG, she's got a PO2 of 53 millimeters of mercury on 2 liters, and her lactate dehydrogenase is 1,431. I think you're going to guess one too, but what's the diagnosis? Mycoplasma is number 1, cryptomycosis is number 2, pneumocystis is number 3, and hypersensitivity pneumonitis is number 4. So it's a talk about infections, so probably not in this context going to be hypersensitivity pneumonitis. All right, so you killed it. So indeed, She has pneumocystis. She goes into progressive respiratory failure. She's very sick. Mechanical ventilation. She has an alveolar lavage, and a direct fluorescent antibody is positive on it. And she started on trimethoprim sulfamethoxazole and steroids. She goes on to need extracorporeal membrane oxygenation, and she passed away trying to fight this infection. So pneumocystis remains our chief pulmonary fungal pathogen within the HIV community, with worldwide 400,000 cases. The CD4 count less than 200 is the context to think about this for the index of suspicion. The mortality rate is 10 to 30%, as we saw in this case. It's preventable with prophylaxis, primarily trimethoprim sulfamethoxazole, although there are some other agents that are also options that you can see there, similar to what we do in lung transplant prophylaxis for PJP. The presentation can be indolent or fulminant, and it tends to be indolent in the HIV population, and it tends to be more fulminant in the cases that we might see in our lung transplant practice. The diagnosis is maybe supported by an elevated lactate dehydrogenase, although that's certainly not specific. That beta-D-glucan can also support the diagnosis, really help rule it out more than anything, given that there's other fungi that can also be positive with that test. The direct fluorescent antibody is better than a silver stain, and when you're testing a sample like a BAL or an induced sputum, and indeed the induced sputum has a sensitivity somewhere between 74 and 83%, and so if you can get the diagnosis that way, that's ideal, although sometimes we have to go to an alveolar lavage in the bronchoscopy if the patient can tolerate it, which gives us very good sensitivity and specificity, and is the way we make the diagnosis a lot. There's a PCR test that's available for diagnosing pneumocystis. It's very sensitive, in fact, maybe a little too sensitive, as it can detect just low-level colonization in some people and could fool you or steer you away from the real diagnosis. How about a high-resolution CT in making the diagnosis? Well, it certainly is not specific enough to make a diagnosis of PJP, but again, when you're thinking about index of suspicion, it may get you there part of the way into the other tests, but also a negative HRCT that does not have ground glass opacities, like this extreme example here. If you don't have ground glass, it's probably, in fact, almost certainly not pneumocystis, and so you can just about hang your hat on that one. The treatment strategies for pneumocystis you can see here. I'm not going to go through all of it in detail, but basically trimethoprim with sulfamethoxazole is the first-line therapy at the doses that you see there, which is high dose. We have to watch out for some things there. If they're not able to tolerate that or fail therapy for some reason, then alternatives are pentamidine or clindamycin with primaquine or dapsone with trimethoprim. And so there's some dosing for that. And then don't forget the steroids. So you have a patient with pneumocystis, especially one who's severely ill. It's something to be important to be considering. So with that said, which of the following is a criterion for using steroid therapy in pneumocystis infection? Would it be number 1, ground glass opacities as your prompt? Would it be an alveolar arterial gradient more than 35 as your prompt for steroids? Would it be that CD4 count less than 200? Would it be coexistent bacterial pneumonia? Or would it be the high lactate dehydrogenase? 1, 2, 3, 4, or 5? Let's go ahead and vote. Oh, I didn't see what you hit there. Oh, you got it. All right. So pneumocystis treatment with adjunctive steroids. This is an old story, but it's one that is stood the test of time. And this is an HIV population, one of a couple of studies that were published around the same time looking at the same topic. Adjunctive steroids in patients with HIV and severe disease had reduced time on the ventilator and days in the ICU and mortality. And so the practice is to use 21 days of steroid prednisone in the dosing regimen you see there. Clinical benefit, however, is not seen, and this is the question that you just answered correctly, in patients who have good oxygenation. So patients with PO2 more than 75 on room air or less than 35 AA gradient, it does not help them, so we don't do it. Finally, case 3 is a 32-year-old woman with CF who had a bilateral lung transplant 4 months prior to the visit, presents with chest pain, and she's on triple immunosuppression. She had been treated with plasma exchange, rituximab, bortezomib, and IV immunoglobulin for an antibody-mediated rejection just about a month and a half before the presentation. And her CT is abnormal as well. And we're so used to looking at lung cuts here. Here's the soft tissue and vascular cuts. You can see a really big ascending aorta there. So there's a pseudoaneurysm, and that's the cause of her chest pain. She undergoes a aortic homograph replacement, and tissue culture has a mold called Cetosporium. This one's the species DeHugai. Here's what it would look like under a microscope with a representative example. She gets started on voriconazole and caspofungin, and she also has something going on in her thigh, a lesion, and it's drained, and it's the same organism. She gets her aortic homograph gets reinfected, and another aneurysm happens, and she gets another homograft. She has persistently positive cultures. She goes on to disseminate with meningitis and a ruptured chordae tendineae, so it started to invade her mitral valve, and she died of overwhelming Cetosporium infection. So there are 3 species, although we saw a 4th one just now in this case, but it's an emerging opportunistic infection. It's a mold that you may see. I've seen it more in the past few years than I had seen it before. It's even present sometimes as a colonizer in patients with some chronic structural lung disease like CF. It's ubiquitous. Polluted water or soil. People can get a puncture wound, maybe walking around barefoot, and seed themselves. Invasive disease, hematogenous spread. You can see all the places it can go. Treatment is difficult. Disease is frequently fatal. Drug therapy depends on the species somewhat, and voriconazole is best for the prolificans species. This is a send out to a specialized lab, actually one in San Antonio that we send to a lot, looking for tailored therapy. Debridement, when possible, is part of the treatment strategy as well as trying to reduce the immunosuppression. In fact, in a review of 80 transplant recipients with Cetosporium from multiple centers, most were disseminated, a little more in the bone marrow transplant than solid organ transplant. The vast majority are in the first 6 months, like we saw in this case. Mortality is high, 58%, worse with prolificans. Those that got voriconazole had a trend toward improved survival, maybe because they had something to treat with, whereas some are resistant to all of our antifungals. And disseminated disease was worse in that study and also more often had surgery. So in the time we've had together to talk about fungal diseases in immunosuppressed patients, we talked about that fungal infections must be considered in immunosuppressed patients, of course, have our antenna up, have that index of suspicion. But the symptoms and findings that we might see are nonspecific, so we're going to need to go further with testing. The correct organism identification is required, so sampling of tissue or fluids or whatever we may have at our disposal is required. Direct smear and culture is often used and sometimes useful, although there are some other techniques with PCR testing or diagnostic assays that we talked about that can be useful as well. The treatment is specific to the organism, and so again, it's why it's so important to get tissue or get samples, including sometimes tissue, to make the diagnosis. And these fungal infections, immunosuppressed, are often lethal, so rapid diagnosis and treatment is desirable when we can. Thank you very much.
Good afternoon. My name is David Snuddy. I'm from the University of Wisconsin, and I'm going to be talking about bacterial infections in the immune-compromised patient. Well, that's a massive topic, and so I've taken the liberty to sort of narrow it to solid organ transplant patients. I think you guys hopefully know how to check in on the polling. Hopefully you're still there. And so we'll get started right away. I have no disclosures that are relevant to this talk. This is hopefully a common figure for all of you, and I just put it here as a reminder to us that the risk for different types of infectious diseases after solid organ transplant really changes with time, which also reflects a change in the level of immune suppression in most of these patients. Initially, in the very first month after a transplant, when patients are very highly immune suppressed and still largely in the hospital, we worry mostly about nosocomial infections, Pseudomonas, MRSA, or VRE. Beyond that, in the time frame of 1 to 6 months, as you can see, immune suppression remains very, very high, and we worry about a lot of opportunistic infections, and that ends up being a lot of fungal infections and viral infections, to be specific. And then as time continues to pass, more and more community-acquired infections are seen, which I think also reflects the tendency to lower immune suppression as patients get further and further out from their initial transplant. Of course, we never forget about opportunistic infections in this complicated population. The risk of infection in immune-suppressed patients also really changes with the type of prophylactic therapy that they're on. And so for patients, in general, we typically widespread use trimethoprim sulfa to provide protection against pneumocystis pneumonia, but this importantly also provides protection against listeria, toxoplasma, and sensitive strains of nocardia. And so you just need to sort of keep that in mind, because if you end up on a different agent other than trimethoprim sulfa, like atovaquone or pentamidine, you don't have that broad spectrum of prophylaxis. In an era of valganciclovir, we certainly, if dosed properly, protect very well against CMV-related disease, but also the other herpes virae. In lung transplant, the respiratory tract is the most common site of infection after transplant, and of those infections, bacterial pneumonia is really the most common type of infection, accounting for about 83% of these cases. Interestingly, the cumulative risk for pneumonia increases sharply in the first 30 days after transplant, and that accounts for nearly 50% of all the risk. Beyond that, the risk continues to climb, as you can see in this figure, steadily up until you get about 1 year out of transplant, and then it sort of plateaus beyond that. Symptoms and signs of infection are often blunted, unfortunately, due to the immune suppression, but they also frequently overlap with symptoms and signs of acute rejection, so it can be sometimes very hard to differentiate between the two. Beyond immune suppression, particularly in the lung transplant population, there are many other predisposing factors to infection, and they're listed here. They include continuous exposure of the allograft with really every breath that the patient takes to the external environment. Colonized native airways, oropharyngeal dysfunction, particularly initially after surgery, allograft denervation, which disrupts the cough reflex, impaired bronchial circulation leading to mucosal injury, decreased ciliary function, and impaired mucus production, disrupted lymphatic drainage as a result of surgery, leading to stasis and edema in the allograft, anastomotic complications that come in all shapes and varieties, donor or recipient-derived infections, particularly in the cystic fibrosis population, and then our patient population in particular has frequent exposure to the healthcare facilities and antibiotic exposure. And so we'll continue to frame our conversation today around this case of a 60-year-old man with severe COPD, and he just has undergone a bilateral lung transplant. He's induced with basiliximab and methylprednisolone. His CMV status is recipient positive, donor negative. He's on typical immunosuppressive therapy otherwise with tacrolimus, mycophenolate, and prednisone, and prophylactic therapy includes amphotericin, itraconazole, ganciclovir, Bactrim, and ceftriaxone. Shortly after transplant, we learned that his donor cultures are growing Streptococcus pneumonia. That brings us to our first question, which is, in lung transplant recipients with early post-transplant pneumonia, what % of donor cultures correlate with subsequent recipient cultures? I think you can see the question and the answers on your phone, so I'm just going to go ahead to the polling. Got a bit of a spectrum of answers. Great. So it's actually quite low. It's only 26%. And that was shown in this study from 2006 that looked at 71 transplant recipients. Of those recipients, 24 developed pneumonia, which is about 34%. Of those 24 pneumonias, 19 had positive donor cultures. But of those 19 with positive donor cultures, only 5 had the causative organism subsequently identified on the recipient culture. There's our 26%. Interestingly, of the 47 transplant recipients without pneumonia, 45 had positive donor cultures. Almost all of them had positive donor cultures but didn't develop pneumonia. And so really the presence of donor organisms does not predict post-transplant pneumonia very well at all. Having said that, it's hard to ignore that culture result from the donor because we know that the impact of pneumonia is so very high in lung transplant recipients. Infection is the leading cause of death in the first year in this population, with an attributable mortality of up to 31% in patients who have 1 or more pneumonias. 1-year survival in this population with pneumonia is reduced at 74% compared to 99% if without pneumonia. And infection and even colonization predisposes to other problems like chronic rejection, which can further impact long-term survival. So our case continues, and unfortunately this patient had a multitude of post-operative complications listed here. He had coagulopathy, which was ultimately found to be factor VII deficiency, requiring multiple transfusions, resulting in a hemothorax that had to be evacuated on post-op day 1 and delayed chest closure. On post-op day 2, he was found to have MRSA on tracheal aspirate and was treated appropriately. He had recurrent aspiration pneumonias, treated at first with piperacillin tazobactam and then meropenem tapered to ampicillin after cultures were unremarkable. And those recurrent aspirations were associated with recurrent hypoxic respiratory failure requiring intubation, ultimately tracheostomy, Dobhoff tube placement, and not surprisingly, atrial fibrillation and acute kidney injury, and importantly, persistent delirium for a lot of reasons, but that ultimately prompted a change in his immune suppression from tacrolimus to cyclosporin on post-op day 11. And so with this rocky start, after post-op day 11, he actually did pretty well and continued to make progress up until day 28, when he developed acute obtundation with fever and leukocytosis. And so a stat head CT was done because of his history of coagulopathy, but no evidence of intracranial hemorrhage was found or acute mass. Bringing us to our next question, which of the following is incorrect regarding CNS infection in solid organ transplant recipients? So we'll go to the poll, which is incorrect. Very good. We've got some variety of answers. Great. So we can talk about this a little bit. So the answer that we're looking for is C. Actually, bacteria account for only a very, very small portion of CNS infections in this population. This is a nice review paper from 2000. Seizures are suggested or are seen in up to 25% of patients. The highest rate of seizures are seen in lung transplant recipients as well as liver and heart transplant recipients. But please keep in mind that most seizures in this population are related to immune suppression and metabolic disorders and not actually infection. For focal CNS infections, they are rarely bacterial in origin. Really, virtually all are fungal. Think Aspergillus. Nocardia is the one bacteria that you should keep in mind. Its incidence is maybe up to 6% of cases. And importantly, nocardia is associated with disseminated disease in up to 40% of patients. Routine bacteria, like Klebsiella, Staph, or Pseudomonas, are rarely seen, less than 1% of the time. And tuberculosis, also very rare. In terms of meningitis or meningoencephalitis, Listeria is the bacteria they need to keep in mind, but this is typically a late complication in transplant patients and frequently associated with concurrent bacteremia. As I've already mentioned, Bactrim is an effective prophylactic therapy for this particular bacteria, but if the patient's not on that, your risk is, of course, going to increase. Other bacteria are rarely causative outside of bacteremia from extraneural sources. So our case continues. Because of coagulopathy, as lumbar puncture was delayed, empiric vancomycin was added, and the ceftriaxone dose was increased due to concerns for meningitis. EEG obtained, showed diffuse slowing but no seizures. Chest x-ray largely showed no acute changes, some bibasilar atelectasis, some small effusions, and stable left chest tube positioning. A CT chest showed a lot of the same, with some evidence of right lower lobe atelectatic collapse versus infiltrate, and some debris in the right-sided bronchi. So bronchoscopy is performed. The question becomes, what approach maximizes bronchoscopic diagnostic yield in immune-compromised patients with infiltrates? We'll go to polling. So how do we best get the answer? Great, we got some variety again. Good portion of people want to just do everything, and I don't necessarily tend to disagree with that much, but the evidence suggests that BAL and transbronchial biopsy are probably all that you need to do. And that's based upon this article from 2004 in Chest. They looked at 104 non-HIV immune-compromised patients with lung infiltrates and sort of defined the diagnostic yield and all the sorts of tools that we use for bronchoscopy. They showed that BAL had a diagnostic yield of about 38%, kind of a little bit lower than I would have expected, but maybe if we think about it, maybe that's right where it actually is. Protected specimen brush, not very helpful, only 13%. Biopsy, 44%. You start combining things, BAL and brush, 45%. BAL and biopsy, big jump, up to 70%. And then BAL with brush and biopsy, 86%. So it seems as if when you add more and more, your yield goes up. But then they did a comparison analysis, and at the bottom you see BAL with biopsy versus BAL alone, and that proved to be significantly better. That's truly something worthwhile to do. But when they compared then BAL with biopsy versus all three modalities, there wasn't a significant extra gain. And so from this literature, it seems that BAL and transbronchial biopsy are probably give you the most benefit and minimize the risk. Importantly, there was no difference in yield between focal versus diffuse infiltrates, as well as between the different patient populations that were looked at. Also very importantly, and I try to stress this with my fellows, transbronchial biopsy provided the exclusive diagnosis for infection in 2 patients. Biopsies can be helpful for infection. They're worthwhile to do it for infection. Yes, most of those biopsies are going to provide non-infectious diagnoses, but don't discount the benefit of biopsy when you're most concerned about infection. Complications are consistent with what you'd see in the literature with minor bleeding and pneumothorax. So our case continues, some initial laboratory analysis around the time of his obtundation. Sodium, not perfect. Creatinine, also not perfect, but getting better. Bilirubin was 2. Ammonia, 196. INR, 3.6. Cyclosporin trough was 181. Urinalysis negative. Right upper quadrant sono and HIDA scans were obtained, and they were unremarkable. Bronchoscopy performed, showed some secretions. Anastomoses looked normal. BAL results showed some neutrophils, some macrophages, some polys. No bacteria, and a viral panel off the BAL fluid was negative. And so that brings us to our final question for this particular part of the session. What is the best additional antimicrobial change that should be made at this time. What should we do? Okay. Some people are very happy with how things are going. Maybe a little extra gram-negative coverage with cefepime. Some variety of answers. And so what I'm going to try to do is make a case for D, adding doxycycline. Because this ended up being a case of hyperammonemia syndrome caused by urea plasma species. And so ultimately on culture of the BAL fluid, we saw urea plasma species. And on analysis of pleural fluid, we also saw the same species by 16S DNA sequencing. So the patient was treated with doxycycline, as well as many other measures to address hyperammonemia. As you might have noted, his ammonia level was about 196 on that two slides ago. And he clinically improved, which is actually quite remarkable because the mortality is quite high associated with this syndrome. And so hyperammonemia is defined as ammonia over 200 in the absence of significant liver dysfunction. It's most common in lung transplant recipients with an incidence of up to 4%, but it's importantly reported in really all other types of solid organ transplant recipients, renal, heart and lung, as well as bone marrow transplant patients and patients just receiving chemotherapy. So you need to keep this in mind. Onset is typically early. In the postoperative period, usually by day 9 or 10, ammonia levels are rising, and the median peak level is reported in this case series of 370. Symptoms are invariably encephalopathy, with or without seizure and coma. Mortality is very high at 70% or greater. And unfortunately, the etiology is very poorly understood. We don't know if this is unmasking of a partial urea cycle disorder, maybe the direct effect of immune suppressive therapy, but now there's growing evidence that it might in fact be related to urea plasma species and other species possibly that split urea. So the evidence for urea plasma comes largely from this case series in 2015, which showed evidence of disseminated urea plasma infection in 6 lung transplant patients with elevated ammonias found at a couple of different institutions in a collaborative effort. And they were all found to have evidence of systemic infection. And then in 20 control patients, no evidence of urea plasma could be found anywhere on any cultures at all. And then in the following year, a mouse model was developed and looked at providing additional support here. And so they took mice and they gave them tacrolimus, mycophenolate, and prednisone, and then challenged them with urea plasma. And they found that those mice that were immune suppressed, challenged with urea plasma, had significantly higher ammonia levels than the control mice. And importantly, immunocompetent mice did not develop any hyperammonemia despite being exposed to the same challenge. So urea plasma species, what do you need to know? There are 2 human species, Urolithicum and parvum. Both have been implicated in the syndrome. It's a common commensal of the urogenital tract. About 2/3 of humans carry this. This species produces the enzyme urase, and a lot of it, much more than any other bacteria, because they rely exclusively on urea hydrolysis for ATP generation. And when urase hydrolyzes urea, the products are carbon dioxide and ammonia, and that's where the ammonia comes from. Importantly, if you're looking for urea plasma, this is not seen on routine cultures. You need a medium with urea in it, and so molecular identification by 16S might be helpful, as it was in this particular case, or you need to talk with your lab and make sure that they plate something out on a media with urea. Treatment for hyperammonemia syndrome is not at all standardized, but it seems to be important that it needs to be multifaceted and implemented early. And so there are some algorithms that have been developed and published, Importantly, antimicrobial therapy should be started early, and agents that are effective against ureaplasma include tetracyclines, macrolides, and fluoroquinolones. Unfortunately, resistance has been demonstrated by ureaplasma to all those agents, and so if you're really concerned about this, combination therapy early in the course is probably warranted. And then introducing methods to reduce ammonia production and absorption, sort of typical things that you might do in the ICU. Bowel decontamination with rifaximin and metronidazole is important. Often patients are, TPN or enteral nutrition is discontinued to limit protein intake, and lactulose is employed to trap the ammonia in the gut rather than have it absorbed. And then increased nitrogen removal with nitrogen scavenger therapies, dialysis, or amino acid supplementation to replace amino acids that may be depleted in urea cycle disorders. And so our key points from this session: the presence of bacteria in donor cultures does not predict subsequent pneumonia in lung transplant patients. But again, it's hard to ignore those cultures. Combined BAL and transbronchial biopsy seems to be the best sort of combination to maximize your diagnostic yield for infection. CNS infections in solid organ transplants are rarely bacteria. Think fungal, think Aspergillus. And then there's a growing body of evidence for ureaplasma infection as a cause of hyperammonemia syndrome. Look for it, check for it, be aggressive about treating it. Thank you.
Good afternoon. My name is Rodrigo Burguete. I'm from UT Health here in San Antonio. I'm in the transplant department. We'll go ahead and get started. Catch up on a little bit of time here. First off, I have no financial, intellectual, or other conflicts to disclose. So the objectives of the talk will be to just list some common viral pathogens that are important in immunosuppressed hosts, specifically any treatable agents. We'll list some diagnostic modalities in the identification of viral pathogens, and we'll describe management of these treatable viral infections in immunocompromised hosts. We'll start with a case. This is a 34-year-old male. He is status post bilateral lung transplant in November of 2016 for CF-related respiratory failure. He presents to transplant clinic with downtrending PFTs. The patient undergoes bronchoscopy, but then later develops fever and shortness of breath. Past medical history is significant for diabetes, sinusitis, and recurrent Pseudomonas infections. His immunosuppression regimen consists of triple therapy with tacrolimus, prednisone, and mycophenolate mofetil. On exam, temp is mildly elevated at 99.8. Again, mildly hypoxemic. He's 93% on 2 liters nasal cannula with a heart rate of 116, blood pressure of 104/73. On physical exam, really fairly unremarkable, has clear breath sounds. Exam, though, was otherwise not significant for anything. CBC and metabolic panel were essentially unremarkable. Results from the bronchoscopy that he had had earlier showed no evidence of rejection. He did have about less than 1,000 colony-forming units of actinomyces. The patient had a chest X-ray. It showed some subtle interstitial and faint alveolar opacities. This prompted a CT scan of the chest. So you can see on CT, multiple bilateral areas of ground glass infiltration. The patient on admission underwent a nasopharyngeal swab with respiratory virus PCR testing. This resulted positive for parainfluenza virus. The patient was at that time on empiric broad-spectrum antibiotics. Despite the broad-spectrum antibiotics, the patient's hospital course was complicated with progressive hypoxemic respiratory failure. His course was fairly abrupt, rapid development of viral pneumonia and ARDS. And as you can see, this was over a span of 5 days with severe worsening of the ground glass opacities. And unfortunately, despite aggressive treatment and care, the patient had progressive decline, a prolonged hospital course, and eventually passed away. As in the non-immunocompromised population, respiratory viruses are the most common cause of respiratory infection in immunocompromised patients. However, their risk of adverse outcomes is far more likely. Respiratory viral infections are an important cause of morbidity and mortality in the immunosuppressed population. This is data from 2 studies. The first one from Lowe is a pediatric study of stem cell transplant recipients. The second is adults with combined stem cell transplant, solid organ transplant, and patients on chemotherapy. As you can see, even though the numbers are somewhat different, the overall rate of hospitalization is roughly the same, somewhere between 30 and 40%. The risk of death, again, also close to around 10% for both populations, and the specifically respiratory virus attributable mortality being somewhere close to about 5% in this population. Specifically in lung transplant patients, both upper and lower respiratory tract infection with respiratory viruses has been associated with a drop in lung function. Lower respiratory tract infection is associated with a significant change in lung function at both 1 and 3 months following infection. From this same study, a nested case control analysis reported significant association between respiratory viral infection within 3 months and episodes of acute rejection. The reported hazard ratio is 6.5. And as far as etiologic agents for respiratory viral infections, in addition to the typical community-acquired agents, you also have to think about opportunistic viral infections. Typically, this is from members of the herpes virus family, including CMV, HSV 1 and 2, and varicella zoster virus. The etiology can be quite variable. In a prospective cohort study of lung transplant patients over 5 years, nasopharyngeal swabs were obtained during any seasonal changes, and also if the patient showed any signs or symptoms of upper or lower respiratory tract infection or of an acute rejection. Detection was by method of PCR. PCR was positive in 11.5% of patients, of asymptomatic patients, and in 55.4% of symptomatic patients. The vast majority of this was due to picoRNA viruses, including rhino and enterovirus. However, you can also see flu and respiratory syncytial virus are an important part there. Coronavirus and bocavirus are emerging viral infections in this population. So prevention is key in this population. An ounce of prevention is worth a pound of cure, as the adage says. All patients that are able should receive scheduled immunizations. All patients that test positive for these pathogens should be placed under respiratory or contact precautions. Immunization of healthcare staff should be performed, and nosocomial infection in bone marrow transplant units is a well-known phenomenon, and it is particularly feared. And antiviral prophylaxis should be done in all patients that are appropriate. In 2013, the U.S. Food and Drug Administration announced permission to use a multiplex nucleic acid test to be marketed in the U.S. This heralded the move toward multiplex PCR testing to be used for the diagnosis of syndromic infections. Molecular assays have now become the gold standard for diagnosis of respiratory viral pathogens. There are some problems associated with this testing. It does limit the number of pathogens that can be tested, so typically you want to test for the most common pathogens. You do need to include any evolving pathogens, so these tests do have to be changed. And you also need to continuously monitor sensitivity and specificity. At this particular hospital, you can see the agents that are detected, and of note, CMV has to be ordered separately, as not with the multiplex panel. Moving on to specific viral pathogens, RSV has long been recognized as a concerning pathogen in immunocompromised hosts. Risk factors for severe disease or progression to lower respiratory tract infection with RSV include recent transplantation, recent rejection, smoking, lymphopenia, age greater than 60, and pre-existing lung disease. RSV is associated with increased mortality with low respiratory tract infection and with increased morbidity and mortality in lung transplant patients. So mortality can vary widely. It has been reported to be as high as 80%. Now, this is in untreated stem cell transplant patients, with the caveat being that these are patients that received absolutely no treatment, including supportive care, or in patients that delayed treatment. Now, if you compare that to patients that are treated for RSV, the mortality drops significantly, reported anywhere from 6 to 25% in stem cell transplant patients, and reported at about 10 to 13% in treated solid organ transplant patients. Treatment options for RSV include antivirals, ribavirin. This can be in inhaled, IV, or oral formulations. The inhaled formulation is particularly problematic. It's a 12 to 18-hour inhalation. It is very expensive. It is teratogenic, so no pregnant women are allowed in the room. IV and oral formulations are somewhat cheaper, but they are associated with hemolytic anemia and with lactic acidosis. We can also use immunomodulators. Typically, IVIG is sometimes used. Anti-RSV monoclonal antibody, palivizumab, is available. Previously, Respigam was available. However, this has been recalled and is no longer available in the U.S. And there are some investigational agents that are available. ALN-RSV01, which is an interfering RNA. It does potentially prevent BOS in lung transplant recipients. RI-001 and 002 are anti-RSV neutralizing antibodies. And GS-5806 is an RSV entry inhibitor. It has been shown to lower viral load, decrease mucus weight, and decrease symptom score. It is currently being trialed in lung transplant recipients and bone marrow transplant patients. As mentioned previously, the cost of inhaled ribavirin has risen significantly. In 2013, the cost per day for one inhalation was approximately $6,000. In 2018, this is now listed on Lexicomp at $29,953. And just to put that into perspective, the 100-day cost of an allogeneic stem cell transplant is at about $203,000. So a 10-day course for someone with RSV will rival that of a stem cell transplant. Now, comparing oral versus inhaled ribavirin, this study took two groups, treated them both with ribavirin, one group with inhaled, one group with oral. This is in lung transplant recipients, and they compared FEV1 at presentation and at 6-month follow-up. There was no statistically significant difference in change of FEV1 in the inhaled versus the oral group. Also, they tested for BOS greater than 1 at presentation. There were only 3 patients in the inhaled group, and for any progression of BOS at 6-month follow-up. Again, these are non-statistically significant differences. So it is very likely that oral ribavirin is non-inferior to the inhaled formulation. So as far as management of RSV, most centers will treat with ribavirin, and I think more and more centers are leaning towards oral, simply because of cost issues. The efficacy is likely the same. IVIG is done at some centers, usually dosing every 48 hours, and of course supportive care. Moving on to influenza, there is increased severity of influenza in lung transplant recipients and increased attributable mortality in the transplant population. Risk factors for mortality include an ANC less than 200, rise in creatinine, a delay in seeking care, but most importantly, a lack of flu-specific treatment. So it is important to treat these patients. Influenza is associated with higher hospitalization, higher need for imaging, higher abnormal imaging. There is increased ICU admission and mechanical ventilation, and as well as increased death attributable to influenza. Again, prevention is key. Vaccination for all patients that are able. Inactivated vaccine only for immunosuppressed patients. It is recommended between 2 to 6 months post-transplant. We also have chemoprophylaxis available. Both oseltamivir and zanamivir are FDA approved for chemoprophylaxis. And neuraminidase inhibitors are the mainstay of treatment, with oseltamivir being the oral formulation, zanamivir inhaled, and peramivir IV. Early treatment is associated with improved outcomes, decreased hospitalization, and a decreased need for mechanical ventilation. The duration in non-immunosuppressed adults is 5 days, but it can be extended in immunosuppressed patients. On the horizon, this is from the New England Journal of Medicine, and this is, can also be seen as a YouTube video from the New England Journal. Baloxavir marboxyl, this was from September. This is a novel agent used for the treatment of influenza. It inhibits viral mRNA replication. It has been shown in a randomized double-blind placebo-controlled trial of about 1,400 patients. They gave these patients either baloxavir, oseltamivir, or placebo and compared time to alleviation of symptoms. Median time to alleviation of symptoms was 26.5 hours shorter compared to placebo and was the same compared to oseltamivir. There was no difference in adverse effects, including nausea, diarrhea, bronchitis, and nasopharyngitis. Quickly, we'll move on to a second case. It's a 73-year-old male with pulmonary adenocarcinoma, a malignant left diffusion, and brain mets. He presents with shortness of breath, hypoxemia, and fever to 100.4. Past medical history is listed, and his immunosuppressant medications include pemetrexed with carboplatin, as well as immunotherapy with pembrolizumab. Patient was found to have, again, bilateral ground glass infiltrates, as well as the known left effusion. The patient underwent a bronchoscopy and was found to have a CMV. This was not a quantitative PCR, but he also had CMV in plasma that was shown to be rising. His BNP was not elevated. He was not felt to be in heart failure. He was treated with steroids given the concern for pembrolizumab-associated pneumonitis. CMV is the most common viral infection after organ transplantation. It has a major impact on morbidity, mortality, and graft survival. And optimal prevention, diagnosis, and treatment does significantly impact outcomes. It can affect a wide variety of organs, including the lungs. It can cause colitis, hepatitis, CNS disease. It can affect the kidneys and the heart. Now, infection does not necessarily mean disease. It's important to note that. CMV infection is just defined as replication, evidence of replication, whereas disease is evidence of replication plus attributable symptoms. In the transplant population, optimal CMV prevention after transplant can significantly improve outcomes. The two modalities that are used are universal prophylaxis versus preemptive therapy. Universal prophylaxis involving antivirals for all patients, or at least all patients that are high risk due to serology status. It is better for early disease, less incidence in the first 6 to 12 months. There is more drug toxicity. This is compared to preemptive therapy, in which you monitor CMV PCR in all patients and then start patients on treatment trying to preempt disease in those who have a positive test. This is better for late disease after 12 months, and there is significantly less drug toxicity. Now, for kidney and liver transplants, this is comparable as far as which one to use. However, for lung and heart transplants, given the higher incidence of CMV, we do typically use universal prophylaxis. Diagnosis consists of serology, culture, antigenemia, quantitative nucleic acid testing, and histopathology. Serology is useful only for pre-transplant risk stratification. Culture is slow, it is expensive, and less sensitive. Some of these tests have poor specificity, although it is good for GI disease where antigenemia or QNAT can be negative. Antigenemia is semi-quantitative, it is less expensive, and it has a role basically only if you do not have quantitative nucleic acid testing available. But quantitative nucleic acid testing, which is also known as viral load or PCR, is the cornerstone for diagnosis and monitoring. It can be done on blood, plasma, or BAL, and it can be used for monitoring in patients that are on therapy. Histopathology is the gold standard for tissue invasive disease, but it does have associated risks with transbronchial biopsy in patients who have impending respiratory failure, and you also cannot monitor patients with this. PCR in BAL samples was compared to plasma CMV PCR, and as you can see in these ROC curves, when the area under the curve of 90% using these cutoffs, it has a higher sensitivity and specificity than plasma PCR for CMV pneumonitis, so it is a useful tool. Treatment of CMV is with antivirals, with a reduction in immunosuppression, and with supportive care. The role for CMV IG is unclear. Now, treatment with antivirals, Valcyte versus ganciclovir. We know from the Victor trial that treatment success is likely equivalent. There was no statistically significant at day 21 and day 49 in comparing oral valganciclovir versus IV ganciclovir. The CMV treatment guidelines for solid organ transplants were published this year, and just some pearls from those guidelines. If you have mild to moderate disease, oral valganciclovir is recommended. If you do have severe disease, would recommend the IV ganciclovir. You want to reduce immunosuppression if you have severe disease and are not responding with high viral load, with cytopenias, and you want to make sure that the patient is not in acute rejection. You want to monitor renal function and adjust the dose accordingly. And you also want to monitor weekly quantitative nucleic acid testing or viral load. You want to treat for at least 2 weeks, but you do want to make sure that they have resolution of symptoms and eradication of viremia by QNAT testing. If you have a failure to respond, you want to think about drug resistance and test for any mutations. So just to wrap up, take-home points, viral infections are associated with high morbidity and mortality in immunocompromised hosts. These can be rapidly fatal. You do have a decrease in FEV1 in lung transplant recipients with an increased risk of acute rejection. Prevention is key, with prophylaxis, vaccination, and isolation being used. Diagnosis is done by PCR with multiplex panels. For CMV, you can use PCR testing on BAL, and you want to treat the treatable agents. So thank you, and enjoy your time in San Antonio.